Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. Pericardial disease sits right at the intersection of cardiology and rheumatology. And for a long time, patients have too often fallen into the space between them. Cardiologists are comfortable with the diagnosis, the imaging, the hemodynamics, and we rheumatologists are comfortable with inflammation, autoimmunity, and immunomodulatory therapy. But many of these patients need both perspectives at the same time. What makes this especially important now is that the field is rapidly changing. We're moving away from thinking about pericarditis and myocarditis as completely separate silos, and more towards a broader view of inflammatory heart disease. In addition, we've figured out that some patients may have more of an autoinflammatory pattern to their disease. Others may have an autoimmune pattern, and many fall somewhere in between. Today's episode is about that overlap, how rheumatologists should think about pericarditis and myocarditis, when we should get involved, how the diagnosis and imaging fit in, and how treatment is evolving, especially the growing role of IL-1 blockade and other emerging therapies. My guest today is Dr. Dor Lotan, an assistant professor of medicine at Columbia University Irving Medical Center and New York Presbyterian in New York. He's an advanced heart failure cardiologist with expertise in cardio-rheumatology. Dr. Lotan founded and serves as the medical director of the Center for Pericardial and Myocardial Disease at Columbia University Medical Center, where he developed a multidisciplinary program that brings together rheumatology, cardiology, advanced imaging, and cardiac surgery to care for patients with inflammatory heart disease. He's at the forefront of pericardial disease research, including leading international clinical trials for patients with these disorders. Enjoy. Dor, welcome to the show.
Hi, John. Thanks for having me.
So we're going to be talking about pericarditis, a little bit about myocarditis, but let's step back. How do you think rheumatologists should be thinking about pericardial disease today?
Well, John, you're really starting with the million-dollar question. And honestly, I would broaden a little bit because it's really how both rheumatologists and cardiologists should be thinking about pericardial diseases today. The reality is that even now, pericardial disease still too often falls into this uncomfortable space between specialties. Some cardiologists are very comfortable diagnosing pericarditis, but get less comfortable once the management moves into steroid-sparing agents, for example, biologics, or broader immunomodulation. But on the other side, rheumatologists are naturally very comfortable with inflammation, immune-mediated disease, but may understandably pause when the patient has a large effusion, hemodynamic concerns, arrhythmias, or rising troponin. So patient can end up bouncing between both worlds, when in reality, they usually need both worlds in the same time. And that gets into the heart for your question. Is pericardial disease autoinflammatory, autoimmune, or both? And I think the most practical answer is that it is often a blend, and the proportion probably differs from patient to patient. There are definitely patients who look much more autoinflammatory. They have that classic recurrent phenotypes, dramatic flares, high CRP, symptoms-free intervals, and good response to anti-inflammatory medication. That biology feels very innate, immune-driven. But then there is another group. Pericardial disease is clearly part of a broader autoimmune picture, such as lupus, vasculitis, rheumatoid arthritis, and more, where the pericardium is really one target organ within a larger immune process. And then, of course, there is a large middle group. And that is where real-life practice becomes interesting because many patients do not read the textbook. They may start with what look like idiopathic or post-viral pericarditis, and over time reveal features that make you think more broadly. They recur, they become steroid dependent, they develop extracardiac clues, and sometimes the myocardium becomes involved as well. And once the myocardium is involved, the conversation becomes even more important because now you are not just treating chest pain or an effusion, you are dealing with inflammatory heart disease across a spectrum. And I actually think one of the most important to your question, conceptual changes in recent years is exactly that. We are moving away from thinking of pericarditis and myocarditis as totally separate silos. The 2025 European Society of Cardiology guidelines really reflect that shift by framing this condition under inflammatory myocardial and pericardial syndrome, or IMPS, emphasizing that overlap is common and clinically meaningful.
When we think about pericarditis and myocarditis, can you provide a little bit more detail about how these diseases are diagnosed? So, how do we diagnose pericarditis and how should we diagnose myocarditis?
Right. So, definitely, as I said, these two syndromes may overlap, but each one of them may present a little bit differently. Pericarditis patient, they need to come with definitely chest pain, pleuritic chest pain, but get worse when they're lying flat, relief when they're leaning forward, and we should have some supporting criteria. You can go back to the ACC concise guidelines, looking at the definition and the inclusion diagnostic criteria for pericarditis, and they give us some room. We have a definitive diagnosis or a possible diagnosis, and it really depends how many findings or how many features the patient present. We definitely look at their symptoms. That definitely has to have chest pain, but we can look at inflammatory markers, listen to their heart, listen for pericardial rub, EKG changes, or pericardial effusion, or positive MRI. If you meet two of these diagnostic criteria plus chest pain, it's definite pericarditis, and we should start thinking of pericarditis and initiate therapy. If you hit one of these domains, it's a possible pericarditis, and we may start therapy or just do an additional workup. For myocarditis, a little bit different, right? Patients still present with some chest pain, but they have rising troponin. And the overlap between these two syndromes are important. There is two other definitions that we are using quite frequently in our practice. Perimyocarditis, which myocarditis is the dominant form when we see patients with reduced ejection fraction, rising troponin and chest pain, which will trigger us to treat them more in the myocarditis pathway, or myopericarditis, where pericarditis is the dominant form. We still have troponin. The left ventricular function or the heart function is still preserved, and we treat them more as pericarditis because treatment do differ between two scenarios.
That is super, super helpful. So, when thinking about myocarditis, you mentioned the need for the elevated troponins. Do you also require imaging to show that the patient has myocarditis, or can you make a presumed diagnosis of myocarditis when you have somebody with chest pain and elevated troponins? And I guess, how do you distinguish that from like a myocardial infarction that may also present with chest pain and elevated troponins?
Yeah, that's such an important question. And I think for many rheumatologists, myocarditis can still feel a little intimidating, and understandably so, because the stakes are high and the presentation is often much less straightforward than pericarditis. And if I had to distill the key message, it will be this: myocarditis is not one disease and it's not one presentation. It's really a syndrome. It can range from a patient with mild chest discomfort, modest troponin elevation, and preserved function, all the way to fulminant inflammatory cardiomyopathy with arrhythmias, shock, severe ventricular dysfunction, or the need for mechanical circulatory support or even heart transplant.
Hmm.
So the first thing rheumatologists should understand is that the term myocarditis covers a very broad clinical spectrum. The second thing is that myocarditis should not be thought of only as a cardiology problem. In many patients, especially in rheumatology world, myocarditis may be the cardiac expression of a broader immune-mediated process. It could be part of lupus and vasculitis, like I mentioned earlier, but could be now a checkpoint inhibitor-associated myocarditis. So when rheumatologists see myocarditis, I think the right mindset is this is an isolated cardiac event, or is one organ manifestation of systemic inflammatory disease? And another major point I would like to mention is that the diagnosis is often probabilistic, right? We do not biopsy everyone. Endomyocardial biopsies still matter tremendously in selected patients, especially when the presentation is severe or atypical or fulminant, or a specific diagnosis would clearly change therapy. But in many cases, we're putting the story together from the clinical presentation, troponin pattern, ECG, echo, cardiac MRI, sometimes PET, and the broader systemic context. So we know that uncertainty is part of the field. You often have to act thoughtfully, even without absolute histologic proof. And I also think it is critical to appreciate that myocardial inflammation can leave a scar even after the active inflammation improves. That matters because patient may look clinically better, but still remain at risk for ventricular dysfunction, arrhythmias, or persistent exercise limitation. So, in other words, myocarditis is not just about surviving the acute episode, it's also about what happens 6 months later, a year later, and sometimes even much longer. So, to your question, yes, we do MRIs in myocarditis. We need to meet the criteria of T1 and T2 by Lake Louise to make sure that we are on the diagnosis, and the pattern that we look at the MRI is differ from infarction to non-ischemic process such as myocarditis. So definitely MRI is a key tool for our diagnosis.
And you mentioned about sort of rheumatology involvement in these syndromes. I always struggle to figure out when rheumatologists should be involved. Sometimes we get paged to the emergency department in somebody that has pericarditis because the CRP is elevated. Is that a rheumatology issue? Same thing with myocarditis. Patient is diagnosed with myocarditis and sometimes rheumatology gets paged. And I always struggle, like, as you mentioned, these diseases, probably there's an overlap. But, what are the features that would suggest that maybe the patient has an underlying rheumatic disease? Or what are the instances where you think a rheumatologist should be involved in the care of these patients?
Well, it's a great question because I'd say earlier than many people think.
Hmm.
Rheumatology often gets involved only after patients have had multiple recurrences, become steroid dependent, or start showing clear systemic features. But ideally, we should involve them before that. In pericarditis, I think rheumatology should be involved when the course is no longer behaving like a simple self limited episode. For example, if the patient is recurring, has persistent inflammation, cannot taper steroids, is not responding well to colchicine, or has extra cardiac clues like joint symptoms, rashes, fevers, serologies, Raynaud, cytopenias, pleuritis, or any sign of systemic inflammation. In myocarditis, my threshold is even lower because the stakes are higher. If myocarditis is suspected in someone with known or possible autoimmune disease, or if there are features suggesting myositis, vasculitis, sarcoid, lupus, Sjorgen, or any other overlap syndrome, rheumatology should be involved early. And just as importantly, John, once treatment starts moving towards steroids, steroid sparing agent, IL-1 blockade, mycophenolate, azathioprine, retox, or other immunomodulators, this is exactly where rheumatology adds major value. So overall, I think the right time is when the disease is recurrent, refractory, steroid dependent, systemically inflammatory, diagnostically unclear, or involve the myocardium. So the best outcome usually happens when cardiology and rheumatology works together early, not sequentially after the disease has already become complicated.
That's why, centers, I guess, such as yours, where you have cardiologists and rheumatologists working together, may really benefit patients. Do you guys have sort of like in the inpatient setting, a structured way or like an algorithm whereby you evaluate these patients and you get each other involved in the evaluation and management of pericarditis and myocarditis?
Yes, 100%. And thank you for bringing this up. When we started our center a couple of years ago, we made sure that we have enough infrastructure and support before launching such a program. From my former life or my former career, I understood very clearly that once I opened the doors for pericarditis and myocarditis cases to as a dedicated center, the patient will come,
Hmm.
and this has proven itself. So we hired an NP and we have two RNs, and I can talk about a little bit later about our structure in a kind of more in a complete manner. But we kind of created an inpatient referral line, outpatient referral line, and we are covering the tri-state area and beyond.
Wow.
So now when patient had pericarditis and myocarditis from the inpatient side, rheumatology is getting called, but also I'm getting called, or my team is getting called. And we're definitely trying to get involved with all of these patients. If not in the inpatient side, so for sure it's the outpatient side. And we work with a close collaboration with a lot of disciplines across the institution and the network to make sure that these patients have been caught earlier, putting on the right therapy, on the right dose for the better outcome.
Yeah, that must be so important. So let's talk a little bit about treatment. So, thinking about just somebody presenting with acute pericarditis, maybe it's their first time. What's your go to drug for those patients?
Yeah, I really think of acute and recurrent pericarditis as related conditions on the same spectrum, but they require a very different mindset when it comes to treatment. For acute pericarditis, my approach is still fairly classic. I want to make the diagnosis with confidence, make sure there are no high risk features or red flags, and then treat early and adequately with high dose aspirin or NSAIDs together with colchicine.
Hmm.
I also emphasize exercise restriction until the patient has been getting into remission and close follow up until the patient is truly in remission, not just feeling a little better. The reality remains the foundation of care in both the ACC concise guideline and the 2025 ACC recommendation. But where my approach has changed the most is in recurrent pericarditis. Years ago, we often treated it as a simply more of the same. More NSAIDs, more colchicine, and then steroids if things were not improving. But now I think much more in terms of phenotyping this patient. Is this clearly inflammatory? Is the CRP is elevated? Is there is fever? Is there CMR evidence, MRI, of active pericardial inflammation? That is really how I frame the next step. And that is where the newer ACC guidance, I keep going to it because this is a very relevant document that I recommend everyone to read by the American College of Cardiology, is really important because it really pushes us to think mechanistically. In patients with inflammatory recurrent pericarditis phenotype whose first line therapy is failing, ACC support moving to IL-1 blockade before steroids, while steroids are reserved more for non-inflammatory phenotypes or patients with systemic autoimmune diseases. That is a major shift because it moves us away from the old stepwise reflex of just adding prednisone whenever things get difficult, right? Have definitely become more cautious with steroids over time. I still use them, but much more selectively, usually at low or moderate doses, and usually only when there is a specific reason, such as intolerance to NSAIDs or colchicine, for example, treatment failures, pregnancy, or clear autoimmune context to this patient phenotype. And ESC, the European guidelines are very aligned with that. That makes the point that corticosteroids should not be the first default first option unless there is a clear indication. And in practice, a lot of what we are trying to do now is avoid creating that steroid dependent recurrent pericarditis cycle. And lastly, and honestly, the biggest change in the field has been the IL-1 blockade that has really changed recurrent pericarditis from something we used to repeatedly suppress into something we can treat much more strategically. We should think of recurrent pericarditis as a self-perpetuating cycle that needs to be stopped to treat the current flare and prevent the cycle to go on and hopefully prevent the next one.
Got it. That makes a lot of sense. So avoiding steroids, early on using NSAIDs and colchicine, and then if it becomes recurrent, then thinking about IL-1 blockade. When do you make that shift? When does a patient with acute pericarditis become a patient with recurrent pericarditis?
So there is definition. Acute pericarditis is definitely the acute event. The first presentation, who patient present himself with pericarditis. Recurrent pericarditis, we need to have a symptoms-free interval of 4 to 6 weeks between these two events to declare recurrent. And if they don't really improve themselves, we call it incessant pericarditis, which is kind of like a chronic, or how I like to say to patients, smoldering pericarditis that it may be undertreated with medication that we are prescribing, but they've never been well after the acute event. And this is really makes a difference between acute and recurrent pericarditis.
Got it. So both for the incessant and the recurrent pericarditis, it's when you think about IL-1 blockade? Or what do you do for that incessant, patients that aren't getting better with like NSAIDs and colchicine?
Right. So this is a really important question because I think this is the majority of patients who are coming to see us in a specialized center. Because the question is why they are incessant. Maybe they were underdosed with ibuprofen 200 twice a day, and definitely is way behind the real dose that we should prescribe 600 to 800 milligram ibuprofen 3 times a day. Maybe they're just one colchicine a day and they're way over 70 kilos or 150 pounds or so. So they need to be on twice a day colchicine. So first I ask myself, can I optimize their current therapy? My default is always to go to the good old NSAID or aspirin plus colchicine. It works the best, right? And we have so much data coming all the way from the early 2000 to 2010s-ish on colchicine as a novel drug to prevent recurrences. So we still really like colchicine. We use it very often with all of our patients. But the question is if they are incessant because they are not responding to under therapy, or maybe they are optimal therapy, but they are still symptomatic. If they are still symptomatic despite being an optimal therapy, I may switch NSAIDs, taking ibuprofen, switch to indomethacin, try to up titrate the colchicine, maybe add a little bit of steroids. Like I tell my patient, I'm going to sprinkle you with some steroids on top of the NSAID just to make sure that what I'm seeing here is a true inflammatory presentation versus just a memory pain or non-inflammatory or non-pericarditis pain. And then, the other bucket is definitely the recurrent pericarditis cases that I wait and see. If they come to me and a flare and it's a recurrent flare, I always look back and see and check why they were treated for the first episode. I may replicate if they had a good response, or maybe switch NSAIDs, switch my tools, I would say, when I'm treating them. And if they failed the second recurrent, this is where I'm starting to think, and again, depends on the patient and the patient scenario, whether I should switch over to the interleukin 1 blockade.
Got it. And so there's this term recurrent idiopathic pericarditis. So the idiopathic part, always is challenging. How much are you looking for underlying triggers or causes for the recurrent pericarditis? Or, if it's recurrent, do you just assume, oh, it's idiopathic?
Right. So I think this is one of the idea behind the specialized centers, because we all quote the idiopathic post-viral pericarditis. We still know that it's over 90% of cases patients who present with recurrent pericarditis. But I think these are everyone are kind of citating and quoting older guidelines when we knew maybe less. We had less serologies and less tools to diagnose our patients. In practice, when I'm seeing a patient with recurrent pericarditis, and after I do a very thorough history physical exam, I try to put this patient in different buckets, right? Whether it sounds very classic, 20 years old, post-viral pericarditis, which I just need to treat with anti-inflammatory and move on, versus someone who have very persistent steroids dependent or colchicine resistant recurrent flares. And I always try to kind of deep dive and start to see if there is more to the story. And it really depends on where are you in the world in terms of etiology, what are your risk factors or your other comorbidities, because pericarditis causes, I can list over 90 different causes
Wow.
of pericarditis. But if I need to put them in bucket, definitely idiopathic post-viral is the most common one. But we have post-cardiac injury syndrome. Patients are, even after ablation, after heart attacks, after cardiac surgeries, or any trauma to the chest, can develop pericarditis. Malignancy, it's a growing, obviously has pericardial effusion and they have a pericardial involvement. Tuberculosis in specific parts of the world is still a concern, right? Bacterial, fungal, we don't see it as often, it's extremely rare, but it's still one of the causes. And then we have this huge bucket of autoimmune and autoinflammatory, which we are kind of always trying to deep dive and understand where we put our patient are. And then definitely I can send some basic labs. This is kind of my first get-go with ANA, some serologies, depends on the patient presentation. And if I feel, I get rheumatology involved and continue the workup with them.
You ever think about genetic testing for some of these like autoinflammatory diseases? I always wonder about patients with FMF mutations, MEFE mutations, and whether is that like a predisposing factor for recurrent pericarditis? I don't know. Do you guys think about genetic testing for your patients?
Yeah, 100%. And I think for the first time in the most recent European guidelines, they made a reference for genetic testing. It gave it the level recommendation 2B, which is not high. There's not much evidence, but I really think the role of genetics is going to grow. We are learning that a meaningful subset of patients with multiple recurrences may have a real genetic predisposition, particularly those with younger onset, family history, strongly inflammatory phenotypes, poor colchicine response, or refractory course. And recent data also suggests that about 10 to 15% of patients with multiple recurrences may carry variants in genes related to inflammatory or immunologic pathways, including, as you mentioned, genes as the MEFB, We can see a mutation in TNF-RSF1A and NLRP3 that are all parts of the innate immune and autoinflammatory pathways. MEFV, you were mentioning linked to pyrene and FMF. The TNF-RSF1A is associated with TRAPS, and the NLRP3 is the key component of the inflammasome. So when we find variants in these genes, it can suggest that at least some patients with recurrent pericarditis have a stronger autoinflammatory biology. In my practice, I definitely utilize the genetic panels and autoinflammatory genetic panels in selected cases. And we have started to going, to be honest, it's not uncommonly to see VUSs, variant of unknown significance, coming up back for this test. But I think in the next couple of years, many of these mutations will reclassify. Maybe we'll know more.
Super. Do you ever think about surgery as a potential therapeutic option for patients with recurrent pericarditis?
No, but, but if you look at the guidelines and the concise documents, surgery is still listed as a third option for patient with recurrent pericarditis. I really hope, and I know from my own experience, that nowadays we have way better medication than we had 10 years ago. So I feel that the need for surgery for simply is isolated pericarditis with no any complication to it, I should reserve to very, very, very selected cases after failing many, many lines of therapy and after making sure that we are not missing any other diagnosis.
Interesting. And so, what's the natural course of patients with recurrent pericarditis if you don't treat them appropriately? Aside from them getting, recurrent episodes of chest pain and feeling crappy, can you develop like structural changes to the heart that could impair like heart function down the road?
Yeah, and it's important point, and I will kind of put it as what are the complications for recurrent
Yeah.
pericarditis, and it's important because when people hear complication, they often think only about dramatic cardiac ones, right? But in recurrent pericarditis, the burden is actually much broader. The first and the most common complication that I really like to emphasize and advocate for our patient is more disease, more flares, more emergency visits, more hospitalization, more interruption in work and daily life. Pericarditis really hit our patient quality of life. This is probably the complication feel the most,
Hmm.
even when echocardiogram is not showing something catastrophic. And that is why in recurrent pericarditis, I'm not just treating the pain of the day, I'm trying to break this relapse cycle. Then there are true pericardial complications. We worry about as cardiologists as persistent or enlarging effusions, for example, tamponade physiology, or constrictive or effusive constrictive physiology. The important nuance is that risk is not the same for every patient. An incessant disease can progress to constriction within few months, whereas constriction is extremely rare in uncomplicated idiopathic recurrent pericarditis. So the risk for tamponade and constriction is strongly influenced by the underlying etiology, with much higher risk in bacterial, tuberculosis, neoplastic, or immune-mediated disease than in uncomplicated idiopathic disease. So in practice, when I'm following a patient with recurrent pericarditis, I'm always asking, is this still behaving like relatively uncomplicated idiopathic inflammatory pericarditis? Or is there something about the phenotype or cause that raises the stake? That is where echo remains essential because it tells me whether diffusion is growing, whether there is a hemodynamic consequence, and whether I'm starting to see constrictive physiology. If the story is unclear or the patient is not following the expected course, then MRI become very helpful because it can tell me whether I'm looking at active pericardial inflammation with ongoing edema and enhancement that we can get it with an echo, or a more chronic, scattered, or maybe burned out by now pericarditis. And another complication, and honestly one of the most interesting one right now, is that not all recurrent pericarditis look overtly inflammatory by CRP. We're
Hmm.
increasingly recognizing a lower CRP or so-called a non-inflammatory phenotype pericarditis, and this is not trivial because everyone's say pericarditis ends with itis. I need to see inflammation.
Mhm.
So let's do CRP, let's take Excedrin. But I would be very careful not to dismiss this patient as simply having pain without a disease. Some of them likely have a true pericardial disease biology that just does not announce itself through the unusual or usual systemic inflammatory markers. The challenge is that the pathogenesis is still not fully clear. And this is why the distinction can be hard in real life. So Where management becomes nuanced, a normal CRP does not close the case. It just means I need to phenotype the patient more carefully with the full pictures, symptoms, imaging, systemic context, and treatment response. And lastly, one more major complication is that we need to keep in mind is the treatment toxicity our patient may have, especially repeated corticosteroid exposures in some patients. Part of what is making them sick is not only the disease itself, but the cumulative cost of how they have been managed over time. That is one of the biggest reasons my own practice has changed. I'm much more steroid sparing than I used to be. So if a patient has repeated recurrences and clearly inflammatory pattern, I move earlier toward the steroid sparing strategies rather than letting them live in that flare steroid flare loop that some of our patients are having.
Yeah, totally. And that's a trend for I think all rheumatic diseases is trying to use the lowest doses of steroids for the shortest amount of time. I think you mentioned sort of non-inflammatory pericarditis, which I'm still trying to wrap my head around because we have a lot of patients. Let's say that a patient had an episode of like true pericarditis with like effusions and elevated CRP. You put them on therapy, whatever that therapy is, and they continue having episodes of chest pain. And, trying to distinguish, is this a flare of their pericarditis or not when the CRP is normal? How do you evaluate those patients?
Yeah, that's a great point. And to be honest, we are struggling with this on a daily basis. True. The ACC concise guidance is commenting on it for the first time. And we're recognizing two distinct phenotypes. The inflammatory that we already covered, patient needs to have CRP, needs to have maybe imaging and pericarditic chest pain. But the non-inflammatory phenotype are usually patients that had acute or recurrent pericarditis inflammatory ones maybe weeks or months or years before, but now they present with chest pain, pericarditis chest pain that they well remember exactly like they had several weeks or months ago, but the CRP is not rising. And this is a very challenging scenario. I can tell you honestly, up to 5 years ago, 7 years ago, we wouldn't treat them. We will give them some Tylenol. We'll tell them to go to therapy, trying to find many other agents, but we are definitely not treating them right out of the bat with anti-inflammatory medication. But with the growing evidence of the new IL-1s, we clearly see these patients actually respond to anti-inflammatory therapies. And because we cannot just prescribe IL-1 to anyone come to our door with chest pain with negative CRP, the algorithm recommends us to start low to moderate dose prednisone in these cases. And if they do better, by inclusion, we may switch them to an IL-1. And I can tell you, definitely a good proportion of my patients that come to see me, it's definitely after they've been treated with multiple providers. By the time they come to see me, their CRP is negative, but they may still have some degree of chest pain. So I'm testing them out. Yes, I'm giving them maybe indomethacin or low dose steroids for a couple of weeks. If I see that they do improve, I may switch them over eventually and declare them as recurrent pericarditis. The key here, John, just to make sure that in one point they truly met criteria for acute pericarditis or recurrent pericarditis, to make sure that we don't miss, because the differential diagnosis overall for chest pain is very wide, right? From definitely we need to make sure that it's not acute coronary syndrome or PE or pleuritis or many other reasons. So we need to make sure that we are treating the right disease for the right patient.
Great. That's super helpful because I've struggled, in managing many of those patients. But I like your idea of a trial of anti-inflammatory. So when you use like low dose steroids, what sort of dosing are we talking about?
Right. So it really depends on the weight of our patients. Looking at, again, the guidance papers, we start with zero point 0.2 to zero point 0.5 milligram per kg. But, kind of what I'm trying to do with most of my patients, that I put them on 20 milligram of prednisone, calling them in a week and ask them how they feel. Many of them say, oh my God, the chest pain completely disappeared. What did you do to me?
Love it.
And then I say, okay, I got it. Now my question is whether I'm going to give it a trial and wean them off. And then we need to do a very slow taper over many, many months, 3 to 6 months taper, sometimes a patient on prednisone, or because of comorbidities or risk factors or concern, I'm kind of switching them over for a more sustained steroid sparing regimen.
Okay, that makes a lot of sense. All right. So the other tough challenge that I've had in my clinic is, let's say you have a patient with recurrent pericarditis. You put him on rilonacept as an IL-1 blocker for their recurrent idiopathic pericarditis. They do great. And then what? How do you think about tapering them? When do you taper them? Do you just stop it altogether, or do you just continue it indefinitely? What's your process for how you manage patients who are doing well on IL-1 inhibition?
Uh, Thank you. I was waiting for this question, John, because this is the number one question I'm getting anywhere I go. And this is the most important question in the whole field. And honestly, one of the least fully solved in pericarditis world. My general philosophy is that I do not think about IL-1 inhibition as a short rescue treatment. I think about it as a way to induce a deep remission. And once that remission is stable, I start talking about how to come off therapy. In recurrent pericarditis, one thing I often do in real life is to start the patient on NSAID, aspirin, or sometimes corticosteroid, and then add the IL-1 so I can taper the other agents more quickly and more safely, especially steroids, which are usually the drug I most want to get rid of. But the hard part, of course, as you mentioned, is how long we need to treat this patient. And this is where the field is generally involved. Back in 2020, we published the IRAP, which is the International Registry in anakinra pericarditis. We included 224 patients across Europe, and we were still in the pre-rilonacept era, I want to mention here. And many of us were treating with anakinra for something like 3 to 6 months, partly because that was the mindset we had inherited from the steroid practice and the old guidelines. But IRAP, the registry, really taught us something important. The longer patients were treated, the fewer the recurrences we saw. And a full dose course longer than 3 months, followed by a taper longer than 3 months, was associated with lower recurrence risk. That was one of the first signals that very short IL-1 courses were probably not enough. And then the Rhapsody came, which is the rilonacept trial. And its long-term extension moved the field even further. When patients suspended rilonacept at the 18-month decision point, some recurred, often within a matter of weeks to months, whereas continued treatment was associated with dramatically lower recurrence risk. To be exact, 98% recurrent risk reduction in the Rhapsody trial. So my practical expert view, and I think this is the direction many centers have moved, is that for true recurrent inflammatory pericarditis, I'm usually thinking much more in the range of 1 to 2 years of therapy and sometimes longer, rather than a short fixed course. And then, lastly, there is a real world question that the trials did not fully answer, which is how to stop. When the trial told us very clearly that stopping carries risk, what they did not fully solve is whether gradual tapering is better than abrupt discontinuation of the drug, especially for longer acting agent like rilonacept, because the two trials we have out there on rilonacept and anakinra, both of them had a cold turkey stop.
Mm.
But in real life, many expert pericardial centers, including ours, have moved toward tapering or spacing therapy over time because clinically it seems safer than just stopping and hoping for the best. For anakinra, that approach has some support from the IRAP, as I mentioned, but for rilonacept is still being worked out. So I would favor tapering as an expert opinion, I would say, pattern, rather than settled evidence. And we increasingly taper because it seems to be more sensible and probably safer for our patient, but robust comparative data are still evolving, and I'm watching very closely.
Super interesting. And do you ever put them back on an NSAID or colchicine as you're tapering the IL-1 inhibitor, or just you taper it by itself?
Right. So I have different taper protocols that I use with my patient, and it's a joint decision, right? Some patients would like to space their medication, some want to have different techniques. But I definitely toward the end, or I would say in the middle toward the end of the tapering process, I'm adding again colchicine just as a backup. There is no strong evidence to it. There is some registries that are reporting some outcomes post rilonacept discontinuation or some small case series or center specific. But we do know from trials even before the IL-1 inhibitor came out that colchicine helps with prevention of recurrences. I think the price we pay for colchicine in terms of the safety profile is minimal. And, I don't need to convince the rheumatologist about the added value of colchicine and that was done in different trials, which are not part of pericarditis for cardiovascular disease prevention anymore. So I see a colchicine as a friend as long the patient can tolerate and making sure that there is no drug interaction.
Amazing. So we've talked about sort of where the field stands today, which, less use of steroids, much more frequent use of biologics for the treatment of recurrent pericarditis. Where do you think the field is headed? What are newer therapies that are coming down the pipeline that you're excited about?
Amazing. Because what is especially exciting right now is that for the first time, John, in a long while, recurrent pericarditis really feels like a field with a true pipeline rather than a field of recycling the same few tools. And what makes these newer therapies so interesting is that they are not just new for the sake of being new, they're trying to address the problem we still deal with every day in practice: injection burden, relapse when therapy is withdrawn, the need to match treatment more closely to the underlying biology. The biggest conceptual shift, in my view, is the growing recognition that at least a substantial subset of recurrent pericarditis patients behave like an autoinflammatory diseases, which makes the inflammasome, and especially the NLRP3, a very attractive upstream target with the new development. And that is why oral NLRP3 inhibition is so compelling. If it's proven effective, it offers the possibility of treating the disease earlier in the inflammatory cascade and doing so with an oral therapy. VTX2735, for example, is a peripherally restricted oral small molecules NLRP3 inhibitor, and it is currently in phase 2 development for recurrent pericarditis. So this is definitely one of the programs I'm watching very closely. I'm also very interested in the next generation of IL-1 pathway. We spoke about Arcalyst, we spoke anakinra and rilonacept, but there is new generation of IL-1 pathways that are coming out. And in many ways, you can think of this as evolution as moving from daily receptor blockade with anakinra to weekly ligand trapping with rilonacept, and now toward potentially longer acting receptor targeted monoclonal antibody. Anakinra is a recombinant IL-1 receptor antagonist that blocks signaling from both IL-1 alpha and beta. And we, as you know, we administer it daily. Whereas rilonacept is a fusion protein that traps the IL-1 alpha and beta before they reach the receptor, administered as weekly injection. And right now, rilonacept remains the only FDA-approved therapy specifically indicated for recurrent pericarditis in the United States. But the new agents, and of them is KPL-387, is probably the therapy I'm most excited about right now because it may be the next practical step in how we treat recurrent pericarditis. It is fully human IgG2 monoclonal antibody that targets IL-1 receptor. So it blocks signaling for both IL-1 alpha and beta, but in longer acting and more convenient format. It's currently being studied in a phase 2-3 recurrent pericarditis program with subcutaneous dosing every 2 to 4 weeks, but eventually, hopefully, it will be every 4 weeks. And that really matters because in the real world, many of these patients need treatment for many, many months, sometimes longer years, and the burden of chronic injection is not trivial. So the idea of maintaining a mechanism we already believe in while potentially making long-term treatment easier and more manageable for patients is very appealing. And one more program worth to watching is the CardioRx program, which is a pharmaceutically grade manufactured oral cannabinoidal formulation. It's being studied in the phase 3 Maverick trial in recurrent pericarditis. It's ongoing, including patients who are receiving background of IL-1 blocker therapy for at least 12 months, with the goal of seeing whether patient can discontinue their IL-1 inhibitor and remain free of recurrences while taking the CardioRx. This is a very practical question, what they're looking at, because one of the biggest unresolved issue in this disease, we mentioned it already, is how to help patients come off long-term biologic therapy without simply cycling back into relapses. So I think this is the most novel agent that's been tested now, at least in the United States, and I'm very excited about.
That's super interesting. Great to hear that there's all these options that are hopefully coming down the pipeline. I wonder, when you talk about treatment of recurrent pericarditis, it's pretty complex. I want to hear a little bit about your center that you mentioned with rheumatology and cardiologists and managing pericarditis, and when you think patients should be referred to a center like that. When should patients be comfortable in just following up with a rheumatologist or a cardiologist for pericarditis?
Yeah, for a simple first episode, cardiology can absolutely lead, right? But once the disease becomes recurrent, incessant, steroid dependent, diagnostically unclear or structurally complicated, the best place for that patient is often a specialized center for pericardial diseases. And that matters because recurrent pericarditis patients are often a high touch, demanding patient in the best sense of the word, right? They flare, they call, they worry, they need their concern addressed quickly. This is where a center can build a real infrastructure around care, not just prescribe a medication. In any other world, I can see a cardiologist be able to talk with his patient sometimes on a daily basis to make sure that we induce deep remission. So, in my view, if referral is possible, that is usually what is in the best interest of the patient. My own center, for example, is built around a true multidisciplinary model, as I shared. We have two heart failure cardiologists, one nurse practitioner, two nurses, cardiac surgeons, advanced imaging experts, and two rheumatologists with expertise in cardiac involvement of rheumatologic disorders. We meet regularly to discuss cases and run the clinic in a coordinated way. And we also have 24/7 call center, for example, who are available to our patient to approve access and respond quickly when patients flare. So the handshake between cardiology and rheumatology is the core of a specialized center. If referral is not possible, then autoimmune and immune-mediated cases should at least move into a shared care with rheumatology early because those patients often need more than standard cardiology follow-up alone. So role of rheumatology is extremely, extremely important. So I would put it this way. When feasible, recurrent and complex pericarditis is best managed in specialized centers. But if it's not visible, then autoimmune, autoinflammatory, and refractory cases should at least co-manage early with rheumatology.
I love it. How many of these centers are there around the country? I know you guys have one. We have one at Mass General. Are they very popular, or are there few and far between?
It's a great point. And I think the question to define what is a center and what defines a center, I would say. Whether a center is someone declare himself a center is enough. And because I mentioned the infrastructure is what makes the center really essential for our patient care. And I can tell you from my own experience, this patient, we have high touch point and they're very demanding, definitely when at 20 or 30 years old suddenly have chest pain and is concerned whether he should go to the ED or just reach out to the center he's been taken care of. The American Heart Association initiative identified 18 centers across the country with a special niche on recurrent pericarditis or pericardial syndromes. So you can definitely go to AHA website and kind of look at the closest center to you who are specializing in pericardial diseases. But I hope in the years to come, more and more centers kind of will pop out and more cardiologists will have the interest in cardiorheumatology because the evidence is here, the research is being conducted, and the overlap between cardiology and rheumatology is so intuitive in many of our disease process, and not just pericarditis, myocarditis. We're talking about sarcoid. We're talking so many rheumatological manifestations that collide with the cardiology world. So this is essential for definitely a lot of places across the country.
Amazing. Dora, this has been an amazing conversation. I've really learned a lot. I'm sure our listeners are going to be applying many of the concepts that you mentioned throughout this discussion. It's been really wonderful, and I really applaud you for all the hard work you've done to create your center. That sounds amazing. I think that should be sort of the way that we manage diseases, right? In the future is like collaborative, right? Like have a place where like people talk and work with each other to determine the best therapeutic plan for the patient, and a place that is high touch where patients can call and they can receive responses very quickly. If we could only work toward that end, I think we and our patients would be in a much better place. So thank you so much for your time, Dor, and good luck with all of your future endeavors.
Thank you for having me.
This conversation makes clear that pericardial disease is not just a cardiology issue anymore. Rheumatologists should get involved if the disease becomes recurrent, steroid dependent, diagnostically unclear, or if it involves the myocardium. This conversation also highlights how much the field is evolving with a more nuanced understanding of autoimmunity, autoinflammation, and mixed inflammatory heart disease. And of course, that shift is appropriately changing how we diagnose, co-manage, and treat these patients. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars or however many stars you think we deserve. Show notes for this and all other episodes can be found at acronair.org. Also on Apple Podcast, Spotify, and on your favorite podcast app. Until next time, keep working together with other specialists to help manage our patients. And of course, stay healthy.
This podcast was edited by Resonate Recordings.